Hello guys, very good evening to all of you guys. I hope I'm audible and I hope I'm audible and all right guys. So as you can see today, our topic of interest is antibiotics. We'll do one half of antimicrobial drugs. I hope you had a great week last 7 days. You're able to cover our target. And good evening, Rachel, Ray, Medisco, Farhan. Good evening to all of you guys. So today's session, guys, I'll not take much of your time and let's begin with the antibiotics session today. All right. So guys, is the sound okay now? I hope it is not repeating now. So tell me guys, is the audio and video okay? If it is okay, just give me a thumbs up. All right, so let's move ahead. Let's move ahead, guys. Today's session, I have made keeping antibiotics in mind. I made some clinical cases because antibiotics. They're gonna ask you about clinical cases about how we use those antibiotics. So we'll practice a lot of those. So good evening, guys. Tanisha, Sripriya, good evening to all of you. Let us straight away dive into our first MCQ for today, guys. And a patient suffering from ulcerative colitis. Look at this question. Ulcerative colitis was admitted to the hospital with fever, severe abdominal pain. Patient had diffuse abdominal tenderness, bloody diarrhea. He was diagnosed with fulminant colitis and an emergency therapy was started. Which of the following antibiotics would be most appropriate in this patient? Right? Look at the options. Option A, vancomycin, B, clindamycin, C, metronidazole. Right? So what do you think is the answer, guys? Come on, think. Quick, quick, quick. Let me know the answer in the comment box, guys. Let me know the answer in the comment box. What do you think is the answer here? A, B, C, or D? Vancomycin, clindamycin, metronidazole, or cotrimoxazole? Come on, come on. Let me know the answer in the comment box, guys. Come on. All right. So as I can see, many of you guys have latched onto this word, fulminant colitis, and you have gone for the answer as A, vancomycin. A, vancomycin, which is obviously drug of choice in pseudomembranous enterocolitis, if it is fulminant one. But tell me, is it a case of pseudomembranous enterocolitis, which we're discussing? It is not. So vancomycin is not the answer. In fact, vancomycin, just give me 1 second. In fact, vancomycin is, as I say always, it was the honey trap here. Vancomycin was the honey trap. It was to trap you guys. So you guys were trapped. It is not a case of pseudomembranous enterocolitis. It is a case of colitis because of ulcerative colitis. Ulcerative colitis causing colitis. The causative organism here is a bacteria in your colon, that is bacteroids, which is anaerobes. Right? So in other words, I'm asking you an infra-diaphragmatic anaerobic infection. What is the drug of choice? Your answer is metronidazole. So many of you have given the answer, right? See, clindamycin again. Some of you have commented option B as the answer. B is not the answer. Clindamycin is preferred for supra-diaphragmatic infections, right? Not for infra. So if it is an infection of the oral cavity, let us say, or the lungs, anaerobes, I'll go for clindamycin. But if it is an infection of the infra-diaphragmatic infections, then I'll go for metronidazole. All right, guys, excellent. So as you can see here, the first MCQ itself was a trap. All right, so be careful. All right. Fidaxomicin, Mediscope, yeah, it is drug of choice for pseudomembranous enterocolitis, but not for fulminant cases, right? A patient presented to emergency with 2 days history of high-grade fever, fatigue, breathlessness, cough. Chest X-ray shows bilateral patchy infiltrates in the lungs. A culture sensitivity report is awaited. Which of the following treatment management is best to begin with, right? That's not a difficult question as far as diagnosis is concerned. It's a plumb diagnosis. A. Amoxicillin clavulanate plus azithromycin. B. Amoxicillin clavulanate plus doxycycline. C. Ceftriaxone plus azithromycin. D. Ceftriaxone plus doxycycline. Right. So what is the answer, guys? What is the answer? It's not a difficult MCQ. Tanya Singh, yeah, for infradiaphragmatic anaerobic infection, metro is the drug of choice. That's correct. That's correct. So what is the answer, guys, here? All right, guys. So all of you know this is a case of CAP, right? Community acquired pneumonia. Community acquired pneumonia. And whenever a patient comes to us with community acquired pneumonia, what we do, we start the patient on amoxiclav. Now, why do I start the patient on amoxiclav? Because it can cover gram positive and gram negatives. Like it can cover pneumococcus, it can cover gram negatives like H influenza, Klebsiella, etc. Plus, I start on azithro. As all of you know, azithro can cover the atypical organisms. So by doing this, what I'm doing is, as an empirical treatment, I'm able to cover gram positive, negative, as well as atypical organisms. There is a reason why I'm really proud of all of you guys. Most of you have given the answer right. Option A is the right answer. Option A is the right answer. Now see, if in case in this MCQ, if they would have given you, there is a patient with history of, suppose they would have given you history of penicillin allergy. Penicillin allergy. In that case, you could try this one. Ceftriaxone plus azithromycin if there is penicillin allergy. Now, if the patient can tolerate, because see, some patients with penicillin allergy can develop ceftriaxone allergy as well. If the patient will not respond or is not able to tolerate ceftriaxone, then in that case, we go for fluoroquinolones, the respiratory for fluoroquinolones. So even as empirical treatment, you can use respiratory fluoroquinolones if I'm not able to use a beta lactam. So I always try to use a beta lactam plus a macrolide. If I'm not able to do that, then I can use a fluoroquinolone like levofloxacin, moxifloxacin. They can cover gram positive, gram negative, atypical, everything on their own, but they are slightly more on the toxic side. There is a reason why we use a beta lactam plus azithromycin. So excellent, guys. Abhinandan Maiti, by guideline of CAP where amoxi is not given. No, amoxi is given. It's as empirical treatment, amoxi is given. This is what I'm telling you is the latest guideline. Amoxiclav plus azithro for empirical treatment. It is the latest guideline, right? All right, now let us talk about some current affairs going on in India and related to the state to which I belong to, Odisha. A patient in Odisha presented to the emergency with high-grade fever for 2 days with altered sensorium. There is a history of vomiting and diarrhea as well. On examination, there is an eschar on the lower limb with a black central crust, right? There is also a maculopapular rash on the abdomen. Which of the following drugs should be given to the patient? All right, so as all of you know, um, this is something that I have, picked up from the news that in Odisha, what is going on now. Excellent, guys. So if you have been watching news, you would have been aware of what I'm talking about here, scrub typhus, right? So scrub typhus outbreak has been seen. All right. Now see, you jumped onto option B, oral doxycycline for 7 days. Okay, guys, try to understand. या फरहान अहमद आई नो एम्स में ज़रूर आएगा, पूछेंगे, इसीलिए मैंने एमसीक्यू दिया है. INICET they will ask you this. Now you have to understand, when I say altered sensorium, it means what? Probably he has already developed meningoencephalitis. Probably has developed meningoencephalitis, means involvement of brain and the meninges is there. So the infection, it comes into severe category. And if it is severe category infection, see, most of you have given answer as B, but see guys, B will not be the answer. For this particular patient, I have to admit the patient and start on IV doxycycline for 7 days, right? So usually, if the patient is stable, if the patient there is no CNS involvement, in that case I can go for oral doxycycline, and I can save almost all patients. The only problem is with the diagnosis. People, when they cannot make the diagnosis, that is when people die. If you can make a diagnosis, you can get a very good drug like doxycycline, oral or IV, depending upon what is the severity of the patient. So anyways, you guys tried. B is not the right answer in this case, but it is not a stupid answer. It's a good answer, right? Let's move on to the next question, guys. A female presented to the OPD with complaints of fever and lightning pain in the urethra while micturating. Urine culture was sensitivity testing was done, which showed resistance to all aminoglycosides except amikacin. What could be the mechanism of resistance? So basically, they found a bacteria. They found a bacteria that is resistant to all aminoglycosides. So it's obviously a gram negative because UTI is caused by gram negatives, all of you know, right? And for gram negatives, I can use aminoglycosides. Aminoglycosides are one of the commonly used drugs for treatment of UTI, specifically to increase the activity. Now, this is an MCQ that I made from drugs mechanism of resistance, right? Resistance to all except which one? So it's a very simple question. It's not a difficult one. I told you, right? In these sessions, I'll give you some MCQs which will make you happy, and this is one of those that is going to make you happy. But still, many of you guys are giving the answer is wrong. What is the answer here? Come on, guys. Come on. What is the answer here? This is something I've taught you. Enzymatic inactivation. See, enzymatic inactivation, the resistance, there is exception, and that exception is amikacin. We know about this. Whereas altered ribosomal structure, this is seen only with streptomycin. It is seen only with streptomycin and altered ribosomal structure. This is also a mechanism of resistance to aminoglycosides, but that it is not seen with any other except streptomycin. So, it's netylmycin and amikacin, but netylmycin is not that commonly used nowadays. All right, guys, let's move on to the next question. A sexually active female presented to the OPD with symptoms of frequency and dysuria. Routine urine test shows pyuria, but no microorganism was seen in gram stain. She has history of sexual encounter 14 days back without protection, right? UPD test has also come positive for pregnancy. Which of the following drugs should be used for treatment, right? Doxycycline 100 milligrams BD for 7 days. Azithromycin 1 gram single dose. Levofloxacin 500 milligrams OD for 7 days. Benzathine penicillin G 2.5 million units single dose. What am I going to use here? Right, so it's a simple MCQ because the UPT is positive. PCM is safe in pregnancy. Yes, paracetamol is safe, but why paracetamol? It's a simple MCQ. All right, so excellent, guys. So Naveen Prabhu has even given the diagnosis here. If there is no microorganism, but there is pyuria, this is characteristic of chlamydia infection. Characteristic of chlamydia. For chlamydia, if she would not have been pregnant, I would have gone for option A, that is doxycycline. But since she is pregnant here, I'll go for azithromycin 1 gram single dose. Levofloxacin can also be used. It's not that I cannot use, but again, levofloxacin is also not safe in pregnancy. So these three options are correct. These three, they can be used. I can use. These three can be used. But the only one that can be used in pregnancy is azithromycin. Doxy, not to be used. Levofloxacin, not to be used. Benzathine penicillin G has no activity against chlamydia. The reason being, penicillin G or any beta-lactam for that matter inhibits cell wall synthesis, and chlamydia, their cell wall structure is such that this cannot act, right? So anyways, guys, most of you have given the answer right. And let's move on to the next question. It's a clinical case, long clinical case that I made for you guys. A homeless man was brought to the emergency department who had complained recently of severe abdominal cramping, nausea, vomiting, diarrhea. He has a temperature of 102, right? Blood pressure of 90/60. On examination, patient had an erythematous area, as you can see in the picture, right? With a central ulcer in the abdomen. Which of the following pairs of drug would be most appropriate for the emergency treatment in this patient? And this is a little bit on the difficult side. But anyways, if you can corroborate the findings in this particular patient, look at the most important symptom and look at the image. You'll be able to find the answer. So what I'm going to use here, am I going to use piperacillin tazobactam plus gentamicin? Am I going to use meropenem plus doxycycline? Am I going to use vancomycin plus gentamicin? Am I going to use penicillin G plus clindamycin? What am I going to use? Take your time, take your time. There is no hurry. Take your time and you can answer whenever you feel confident, right? But do commit to one option. Do commit to at least one option. Whatever it may be, you might go wrong. There is nothing wrong in that, right? All right, guys. So, what do you think would be the right answer here? All right. Let us see. Let us see. Let us try to understand. So, you can see this is patient has an ulcer in the abdomen, and this is basically the diagnosis is cellulitis. And one of the common cause of cellulitis, all of you know, is Staphylococcus. I told you it's a difficult one. If you didn't get the answer right, it's okay. So cellulitis, Staphylococcus, and that Staphylococcus causing cellulitis can release toxin and cause TSS, toxic shock syndrome. That is the reason why the blood pressure is so low. The blood pressure is so low, 90/60. That is why the blood pressure is so low, right? 90/60. So it's all about diagnosis. If you could make a diagnosis, the answer is pretty simple. So it is a toxic shock syndrome. All of you know that. The classical example that is given to you guys is about the use of tampon. Even cellulitis can also cause toxic shock syndrome. And now if you know toxic shock syndrome, in that case, what should I be using? I should be using an anti-staphylococcal drug like I can use penicillin G depending upon sensitivity. Plus, I have to use clindamycin. The reason being clindamycin, it will block toxin synthesis. It is used as it is a protein synthesis inhibitor. It would block toxin synthesis and proteins. Toxins are nothing but toxins are proteins. Diarrhea can lead to low blood pressure, but diarrhea cannot lead to so much of low blood pressure, right? So to have such a low blood pressure, you need to have a diagnosis like cholera or something like that. All right. So see, there are a lot of things that can be there. You have to make a differential diagnosis, right? So this is a case of toxic shock syndrome, and there is a reason why D would be the right answer. So I have just made a clinical case related to toxic shock syndrome. All right, look at this. A drug abuser was found. So if you can ignore cellulitis, then keeping diarrhea in mind, you can go for treatment with the drugs which can act on diarrhea, like a fluoroquinolone, IV fluids, etc. You can use, right? A drug abuser was found unconscious on the road by police. He was admitted to Safdarjung Hospital with symptoms of high-grade fever, chills, rigors, pain on micturition, and back pain. Echocardiography, there were vegetations on tricuspid valve. Blood culture was positive for Pseudomonas with good sensitivity to aminoglycosides, carbapenems, ceftazidime, piperacillin, ciprofloxacin. After surgical excision of the lesions, he was started on 2 antibiotics. That is what we were supposed to do in severe infections, right? Severe infection. And look at the options. Tobramycin, gentamicin. Option A, ceftazidime, penicillin G. Imipenem, tobramycin. Ceftazidime, imipenem. Someone has asked me here, sir, why not option A? So why not option A? Why not option A? The reason being, if I'll use gentamicin, it would further kill the bacteria, release more toxins. So you have to understand the basic concept of treating toxic shock syndrome. I have to use one drug that kills the bacteria. I have to use another drug that also inhibits toxin synthesis, and it has to be protein synthesis inhibitor, which is not a cidal drug, it's a static drug, right? So that is the reason why I'm using clindamycin. All right, what is the answer here? tobramycin and gentamicin, ceftazidime and penicillin G, imipenem and tobramycin, ceftazidime and imipenem. All right, guys, what is the answer here? All right, what is the answer? What is the answer? What is the answer? What is the answer? Come on, guys, come on. It's a simple MCQ. I've taught you this. What am I going to combine here? Tobramycin, gentamicin, ceftazidime, penicillin G, imipenem, tobramycin, or ceftazidime, imipenem. What am I supposed to combine here? All right, those who have gone for option B and D, I can understand why you went for option B or D, because all of you know that ceftazidime is a drug of choice for Pseudomonas. So you thought that this anyone would be the answer, and it's a good thought process. But remember, both are not the right answer here. The reason being, see, ceftazidime and penicillin G. What is the logic? Both are cell wall synthesis inhibitors. Ceftazidime, imipenem. What is the logic? Both are cell wall synthesis inhibitors. So there is no logic in combining one cell wall inhibitor with another. I told you this. Whenever you're using a cell wall synthesis inhibitor, right? Like for example, you're using a penicillin or cephalosporin, right? Or you're using a carbapenem. So we use any three of these are most commonly used, right? And to increase the effect, I usually combine this with an aminoglycosides. I combine these with an aminoglycosides. So this is something I've taught you guys. So in your MCQs options, don't just get misguided by looking at the initials of the options. So just by looking at ceftazidime, you got misguided. So answer is obviously, now you have started commenting or giving the right answer. Answer is imipenem and tobramycin, right? Answer is imipenem and tobramycin. So anyways, yeah, so as I said, these are innocent answers, but these are not right answer. You need to have little bit of innocence, that is good, but too much of innocence can cost you your rank, right? So I've told you this to remember the basic concept. Penicillin, cephalosporin. All right, penicillin, cephalosporin, carbapenems plus aminoglycoside. There is the basic takeaway message, right, from this MCQ. All right, look at the next question. A 60-year-old diabetic patient was forcefully brought to the hospital with fever and a throbbing pain in the foot. There was a putrid smelling ulcer on his foot full of pus. Gram stain of the pus showed multiple gram positive and negative cocci and rods. Which of the following antibiotics should be started with culture sensitivity report is awaited, right? What I'm going to use here. Anyways, so yes, if you get some of the answers, if you get wrong, it is okay, it is fine. So amoxicillin clavulanate, clindamycin, linezolid, metronidazole. See, we have to combine an aminoglycoside with a cell wall synthesis inhibitor. Right, so what is the answer here, guys? All right, come on, this is not a difficult one. This is not a difficult one, isn't it? This is not a difficult one. Come on, guys. What is the answer? So A, B, C, or D? So most of you have given the right answer, guys. Here, your answer is option A. The reason being, I have just now I told you, right? It covers both gram positive and negatives. It covers. So as an empirical treatment, even in this case, I'm going to start this one. Clindamycin, well, some of you have given answer as clindamycin. Clinda will not be the answer. The reason being, Clinda cannot cover gram negative aerobes. So gram negative aerobes cannot be covered. It only covers gram negative anaerobes. Linezolid will not be the answer because it covers only gram positive. Metro, it covers only anaerobes. So there is no point in using this. So this is the right answer. All right, moving on to the next question, guys. Another clinical question. A 10-year-old boy was brought to the hospital with fever and joint pain in the knees and wrists, who had throat pain for last 10 days. He had red, hot, and painful knees and non-pruritic rash with distinct like borders in his thighs and stomach. There were painless subcutaneous nodules on his elbows and knees. Heart auscultation revealed a mitral valve regurgitation murmur. He had an elevated ESR and streptolizine O titer. Diagnosis was made and a suitable therapy was prescribed. Which of the following pairs of drugs would be most appropriate for initial treatment of this patient? Sometimes the questions are, see, I have seen this. The length of the question is inversely proportional to the difficulty of the question, right? So it might seem long. All right, so what I'm going to use, guys, here: penicillin G and aspirin, ceftriaxone and acetaminophen, tobramycin and aspirin, penicillin G and acetaminophen. So what I'm supposed to use here? A, B, C, D. All right, so most of you have given. So guys, it is acute rheumatic fever. Acute rheumatic fever, and there is inflammation. So that is the reason why, see, acetaminophen is never an option. Acetaminophen is never an option. Why would you use paracetamol? It is not a good anti-inflammatory drug. It is analgesic antipyretic. Here there is inflammation, right? Arthritis, inflammation is there. So I have to go for A or C. Now see, it is rheumatic fever, means it is caused by streptococcus. Streptococcus. And that is the reason why C cannot be the answer, because aminoglycosides, they inherently do not have activity against gram-positive. So remember, aminoglycosides, they do not have activity against gram-positives. But mind it, aminoglycosides are used against gram-positive if the patient is already on a cell wall inhibitor. Like for example, if a patient is on ampicillin, and I can use ampicillin plus gentamicin for treatment of, for example, what is that? Enterococcal endocarditis. So against enterococcus, gentamicin is not effective. But if I combine ampicillin, it becomes effective. Or I can, in enterococcal endocarditis, I can use Venco plus gentamicin, right? So I told you the use is like that. Yeah, see, actually, aspirin is given not only because of that. Aspirin, the main reason why we're giving it is because of inflammatory response, right? And PCM is not an anti-inflammatory. Excellent, guys, excellent. So most of you have given the answer is right. So you understood why B, C, or D cannot be the answer, right? All right, look at the next question. An IV drug abuser presented with fever, persistent cough, and dyspnea to the emergency. He has been suffering from HIV and is on drugs on and off, but currently not taking any retroviral drugs. He was diagnosed with pneumonia and was successfully treated with gentamicin, right? Which of the following bacteria might have caused this disease? So this is an MCQ that I've made. It goes reverse. It goes reverse, right? So I've given you the drug, and from the drug, based upon its spectrum, I've given you 4 options: bacteroids, enterobacter, chlamydia, and clostridium. And I've asked you to find out where it could be effective, right? So what is the answer, guys? A, B, C, or D? देखो, लंबा क्वेश्चन देख कर डरा मत करो. क्वेश्चन जितना लंबा होता है ना, आंसर उतना ही आसान रहता है. See, Ray's syndrome, Nitin Pratik, Ray's syndrome is seen only if it is viral fever. So don't think that aspirin is contraindicated in children. No, aspirin can be given to children. Aspirin should not be given to children for treatment of viral fever. That's a different thing, right? All right, guys, what is the answer? Let me know the answer. What is the answer, guys? What is the answer? Excellent, guys. Excellent. Excellent. Most of you given the answer right here. And I'm proud of all of you. Answer is B, Enterobacter. So, it's a gram-negative organism. It's a gram-negative aerobe. Enterobacter is difficult to treat. For Enterobacter, usually we use a carbapenem, right? And if it is severe infection, then carbapenem can be combined with gentamicin. Bacteroids, I never use because gentamicin or aminoglycosides are not active against two important inactivity, anaerobes plus typhoid. These are 2 MCQs which are commonly asked. They are not active against anaerobes and typhoid. Chlamydia, they are active, but here the picture is not like this. Clostridium. All right. So guys, are you guys having any issues with the voice? Is my voice clear, guys? Is my voice clear? Is my voice clear, guys? All right. Good, 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 good. All right. So, anyways, guys, let's move on. Voice broken. So, guys, actually, I have this time tried to make it. I've made the settings as such for this live session so that uh, you know um, the lag is lesser, so that we can interact faster. Maybe that's why. All right. Anyways, so guys, let's continue. Newborn term baby born to febrile mother presented with respiratory distress a few hours after the delivery. Physical examination, lab results suggested neonatal sepsis and an empirical antibiotic therapy was started. Later, blood culture indicated listeria as the causative organism. Which of the following drugs would be most appropriate to administer in combination with ampicillin for treatment of this infection? Right. So, doxycycline, gentamicin, ceftriaxone, erythromycin. All right, guys. So, what is the answer? Doxycycline, gentamicin, ceftriaxone, erythromycin for treatment of listeria. So, guys, I've already told you. I've already told you the basic concept. I've already told you the basic concept. The answer is gentamicin. So, time and again, even I've given you around 2 to 3 MCQs already, that whenever uh, I'm using, for example, I'm using here a penicillin like ampicillin. I've told you I'll combine an aminoglycoside to increase the response significantly, right? Response significantly. There is a reason why for listeria infection, I should combine ampicillin with gentamicin, right? All right, guys. A patient presented to OPD with fever and productive cough, thick green sputum. The patient is suffering from severe bronchial asthma and is on high doses of prednisolone, right? See, the patient is on steroids. On examination, he has coarse breath sounds and right lower lung and chest x-ray showed nodule with central cavitation. Sputum showed long branching filaments of gram-positive acid fast rods. Which of the following drug would be appropriate to treat the patient's infection? So it's basically more about diagnosis than treatment. If you can make a diagnosis, treatment is not difficult, right? A doxycycline, B ciprofloxacin, C azithromycin, D cotrimoxazole. There are lots of clues here. One is prednisolone. Second is nodule with central cavitation. Third is uh, long branching filaments. So these are all clues. These are all clues, right? So what is the diagnosis, guys? Excellent, guys. So most of you have given the answer is right. D is the right answer. Cotrimoxazole. So nocardiosis, as you have given, cotrimoxazole. Cotrimoxazole is the right answer here. So see, such kind of MCQs they are being asked nowadays, where you need to have a knowledge of multiple subjects. You need to have a knowledge of both micro and pharma to get the right answer. From micro, you need to get to the microbe, and then once you get to the microbe, you get to the diagnosis, then you get to the drug, which is cotrimoxazole. Now remember, cotrimoxazole uh, two bacteria where they are commonly asking you nowadays. One is I'll talk about that in a short while. Let me come to the next question. An 86-year-old woman complained of burning on urination and bladder pain. Urine culture shows growth of gram-negative organisms, and kidney function tests show serum creatinine levels were raised. She is also a patient of bronchial asthma and is on prednisolone for the same and is on vitamin D supplements for treatment of deficiency, right? She was started on ciprofloxacin and after 5 days of therapy, she developed tendinitis. All of the following could have increased risk of tendinitis in this patient except, right? Old age, vitamin D deficiency, steroid use, renal insufficiency. Okay, let me try, guys. Let me see if I can change it. I cannot change it. But anyways, let us do this session. Let us do this session, right? So what is so guys, one or two questions, one more question is remaining. So please just bear with me for this session. I try to do this session in a different way so that in lesser time we can wrap up the session. Anyways, what is the answer, guys? All right, so answer, guys, here it's is vitamin D deficiency, guys. So vitamin D deficiency has nothing to do with tendonitis. Remember, tendonitis or specifically tendon rupture. Tendon rupture, the risk is higher. The risk for tendon rupture is higher if it is an old age patient, there is steroid use, plus there is renal insufficiency. If these are there, then there is a risk of tendon rupture. So anyways, guys, let us wrap up this session fast because this time, I mean, I did the mistake of setting it in ultra low latency. That is the problem, I think. Anyways, a 14-year-old young football player in the junior team was admitted to the hospital because of fever and severe pain in the left leg. A bone scan showed inflammation in her left distal femur. Blood culture and sensitivity showed growth of staphylococcus resistant to cloxacillin and vancomycin. He was started on a drug that acts by inhibiting protein synthesis by acting upon 30S subunit of ribosome. Which of the following drug most likely was given? So, steroid use has been seen to increase the risk of tendinitis or tendon rupture. Alright, guys, so because the session has already started, I cannot change the latency thing. Anyways, please cooperate this once time, and I'm really sorry because I try to do some experiment this time in this session. But anyways, the last one or two questions are remaining, guys. So what is the answer here? Tetracycline, B linezolid, C tigecycline, D daptomycin. What is the answer here, guys? I'm surprised. Why are you guys answering? See, tetracycline acts upon 30S. That does not qualify it to be an answer. It does act upon 30S, but is tetracycline used against VRSC? Vancomycin, resistant to vancomycin means it is a case of what? It's a case of what? VRSA, right? VRSA, all right, VRSA. So is tetracycline active against VRSA? VRSA, right? So here in VRSA, I can use linezolid, yes, but it acts upon 50S. I can use tigecycline, it acts upon 30S. Daptomycin I can use, but it acts upon the cell membrane. It acts upon cell membrane, right? It acts upon cell membrane. Now you get the hang of it. What is the meaning of this, right? So answer is tigecycline. So I can use B, C, D. A cannot be the answer. A cannot be the answer, though A acts upon the 30S subunit, but it is not effective against VRSA. So tigecycline is the answer. A doctor, while in a medical conference, had street food and then developed diarrhea with abdominal pain and fever. All of the following drugs can be used by the patient except azithromycin, rifaximin, ciprofloxacin, amoxicillin. What is the answer, guys? A doctor, while in medical conference, he had street food, he developed diarrhea with abdominal pain and fever. All of the following drugs can be used by the patient except azithromycin, rifaximin, ciprofloxacin, amoxicillin. Just give me a wild guess. Make a wild guess. What do you think would be the answer here? A, B, C, or D? All right, guys. So here, remember, amoxicillin is the answer. Usually, for traveler's diarrhea, the drug of choice is ciprofloxacin, right? Ciprofloxacin. So it's a case of traveler's diarrhea. And when you travel mostly by a car. Look at this, right? Car. You travel mostly by a car. And the car, C for ciprofloxacin, A for azithromycin, R for rifaximin. These are three drugs that can be used in traveler's diarrhea. Car drugs, ciprofloxacin, azithromycin, and rifaximin. These are three commonly used drugs. The most commonly used drug or the drug of choice is ciprofloxacin. All right, guys. So anyways, so that's all we had to do today, guys. These are the questions I had to do, and I really apologize for today's delay in the voice and video and all, because I tried that I'll make it ultra low latency so that we guys can chat faster. But that experiment surely does not seem to work. But anyways, we did whatever we could do. And guys, this is our next week. I hope it is clear. This is the week 6, and in week 6, we are supposed to do from Monday, Tuesday, Wednesday, Thursday, Friday. You can take a screenshot. I'll post it on Instagram today as well. This is the target where we will be covering the rest of antimicrobial drugs, right? We'll be covering the rest of antimicrobial drugs. And you can take a screenshot of this. And whatever we have to discuss today, guys, I've done. All right, guys. So amoxicillin is not used in this diarrhea. The reason being, there is resistance to the gut microbes like Shigella, Salmonella. We used to use amoxicillin, but now there is resistance, right? Yeah, next week, guys, I'll try to make, so this is the reason why, I usually try to record it and premiere it. This time, the problem was with, as I said, I did some experiment. I wanted the interaction that you and me have, I wanted it to be faster so that I can save your time. That is the reason why I made it ultra low latency transmission. That is where the problem was. So anyways, we'll make it normal next time, guys. And resistance is there. Resistance will come and go. Resistance will develop. And with time, we keep on changing the drugs depending upon resistance. So guys, all the best to all of you for the next 1 week, guys. And thanks a lot for participating enthusiastically. And I wish that you guys have a great week next week. And you can see bit by bit, by next week, we will be done with around 60% of pharma. So 60% of pharmacology will be covered next week until antimicrobials. And week by week, we had been doing this. And I hope you are doing it by the way I've told you, to read, revise, re-revise, read, revise, re-revise. If you had been doing this, then by the end of it, you'll see that you'll come out as a very stronger person with respect to pharma as a subject which is volatile, which you are weak in. It will become your stronger subjects, right, guys? All right, guys. So it does not matter, guys, if you get the answers right or wrong. Does not matter in these sessions. Participation is important, and the most important part is what you yourself do from Monday to Saturday. The most important part of weekly pharma is not this session. This session is not the cake. It's just the cherry on the cake. The cake is what you do from Monday to Saturday. So keep doing that, guys. Take care. Lots of love to all of you. I'll see you next week with the next session. Take care. Bye-bye.